Hi everyone. Today we are grateful to be joined by Dr. Paul Spearman, who will lead us in a discussion about targeted COVID-19 therapeutics. Dr. Spearman is the director of the Division of Infectious Diseases at Cincinnati Children's Hospital. After completing medical school at the University of Texas Southwestern, he went on to complete a combined internal medicine/pediatrics residency at Ohio State University and an infectious disease fellowship at Washington University. Dr. Spearman has spent much of his career in the field of HIV virology, studying how HIV assembles and interacts with host machinery. He is a leader in vaccine development and has led numerous adult and pediatric vaccine clinical trials. His lab is currently developing virus-like particle vaccines for HIV, Ebola, and SARS-CoV-2. In addition, Dr. Spearman currently serves as a representative on the Vaccine and Related Biological Products Advisory Committee within the FDA and the Infectious Disease Clinical Research Collaborative within the NIH. So with no further ado, thank you so much for joining us today, Dr. Spearman, and I'll let you take it from here.
Great. Thank you very much for that introduction. I hope everyone can hear me fine. And I'll start by apologizing for this very informal attire, but hopefully that doesn't put anyone off, as this is like my first day of vacation to see my kids. But it works out great to do the talk. So very sorry to hear about the passing of your classmate. Let's talk about COVID-19 therapeutics. So as you heard, I do more in HIV research and also in COVID vaccines, actually, than I do in therapeutics. So where I learn about therapeutics are when we're asked to see patients, and we are at Children's for therapies, and also what we try to keep up with completely in the literature, which changes all the time. And lots of the literature that we draw from is the unpublished literature, as you probably have gathered throughout the COVID pandemic. It moves so quickly. So there's a lot to cover in COVID-19 therapeutics, and I hope we can make this interesting. All right, let's see. Okay, here are our learning objectives. Let me move this over a little. So first of all, what are the most promising drugs? And as you will figure out very quickly, we're going to talk about antiviral agents and then anti-inflammatory agents, or I will often call them immunomodulators. So those are really the two big categories. And then there are the immunotherapies, the convalescent plasma or monoclonals. So those are what we really have. And so if you kind of group those in your mind, that will help as we go through this talk. We'll talk about what are the standard of care drugs right now and where did they come from? You know, it's only a little more than a year into the COVID pandemic in the US, so how did we get drugs already? As we'll come to, most of these are repurposed drugs, not drugs that have been developed from the time of the pandemic on. And then we'll talk a little bit about how some are used differently in different disease severity. So, you know, how you choose between those and how do you decide what to do, especially with things changing so quickly. And I'll tell you what I do and what my colleagues do. And then we'll talk a little bit about the FDA approval process. I've been involved in some of that, being on the VRBPAC committee. So what do you need for an emergency use authorization as opposed to a full drug approval or full licensure? All right, so first of all, let's think about prevention versus treatment. You might think of drugs that can prevent progression to severe disease in those who have COVID, but are either asymptomatic or mildly symptomatic, versus those treatment efforts where someone has really gotten sick. And usually, again, that's going to be with pneumonia, but it certainly could be with neurologic disease or GI disease, but we really don't yet know how to treat those very well. So again, we'll talk about antiviral therapy, and that can be divided into direct acting antivirals, things that will destroy the ability of the virus to replicate, versus immunotherapy, where you might be able to neutralize the virus or take it out of commission that way. And then the second category really is immunomodulators, things that control the host response rather than the virus itself. So just to remind us as we start this talk, it's been a long pandemic already. We are in a somewhat fortunate position that now we have decreasing cases, but as you keep up with the news, there are many states where cases are going up again. And so we still have to be vigilant and we still need treatments. So, vaccines are looking very, very successful. They still need to be deployed much more widely, but that has really contributed to progress. Therapeutics have contributed to decreased in-hospital mortality, and that is very important as well. We'll talk about some of that. But the virus is still out there, so I just want to remind everyone we're not at the time where we can say that the game has been won. Okay, a little bit about the life cycle, and you guys have probably heard about the life cycle more than what I'll talk about. But as you know, this is an envelope virus. It binds to a receptor, which is the ACE2 receptor. It requires the action of some proteases, one of which is this protease called TMPRSS2 or TMPRSS2 in order to enter. And then an important protein we'll talk about, or at least site of action of the virus, we'll talk about polymerase, because polymerase inhibitors are one of the big targets. So then, of course, the virus has to replicate its genome and make the subgenomic RNAs for making proteins. We won't be talking about assembly. Assembly is very, very interesting for coronaviruses, but so far I haven't seen any real efforts on assembly inhibitors. And even for viruses like HIV, we don't really have assembly inhibitors. But you could imagine during assembly, you could block things like the protease of the virus, and that's going to be a future target that we really can look forward to. Enzymes of viruses are great targets to try to inhibit with therapeutics. Usually, the first target is the polymerase, and that is the case with this virus as well. So we have some progress in that area. Okay, so again, logical therapeutic targets. Where would you look to if you want to block this virus? The RNA-dependent RNA polymerase of the virus has been where several drugs now have been tried, and one is licensed. Proteases might be next. People are working on anti-protease drugs, protease inhibitors. The helicase could be a target. Others, labs are working on things like receptor binding, or knocking out the pathways where the host proteins that are important. So those are really at early stages, though, still. Most of this is developmental rather than even in clinical trials. People have certainly proposed ACE2 blockers for clinical trials, but not gotten very far so far. So that's still a ways from real rolling out. And then, as you all have heard before, there's a tremendous, or if in severe COVID, there's severe inflammatory responses. So cytokine storm, inflammatory cascade, there's lots of ways of describing that. And so modulating that or damping that down is really an important part of what we do currently. So, repurposed drugs versus designer drugs, we have basically everything we have so far is repurposed, and the designer drugs are really still in the pipeline, some of which have entered kind of phase 1 trials, but not too far along. And we'll get into some of those details. One place you can look for coronavirus drugs that are going on is good old New York Times, or, there's lots of other sources, but they're tracking, what's going on in the world of COVID drugs. A lot of people are interested in this. How do we find what is out there, what's going on? Here's how they segregate coronavirus treatments. One FDA approved drug. Great, we have one. So not so far along. Couple others that have been widely used, promising evidence. Then you get down to the pseudoscience spectrum. We'll talk about a little bit of that too, because that has been not a good part of the pandemic, is getting into the pseudoscience. Okay, so here are some of the ones that are on the tracker for the New York Times that are antivirals. And some of these just haven't been evaluated enough yet. A lot of them, but we'll talk about some that have, and some you can just take off the list, basically, like hydroxychloroquine or lopinavir, ritonavir, that have been evaluated and just don't work at all. But remdesivir, and then we'll talk a little bit toward the end about a drug called molnupiravir, which we hope will be a good one for the future. By the way, if you guys want to interrupt me as we go, that is fine with me. If there are questions or if I'm saying something that's not clear. Oops, let me go back. Okay, then there are the immunomodulatory drugs. So as we'll get to, dexamethasone or other steroids, huge impact on the hospital outcomes. That has been a major advance. Cytokine inhibitors, there is some progress with those too, especially tocilizumab and baricitinib. And there are others under evaluation. Azithromycin, not so much. Colchicine, there's some trials, but I'm not very optimistic about that really helping, but it's possible. Okay, now, and just as we start, I would say beware of what you read, because there are so many thousands of articles out there about what to treat COVID with. And I'm not trying to pick on this particular group, but, ginkgo biloba for treating coronavirus. Give me a break. And more information, misinformation. And this is not a political statement, but hydroxychloroquine to jump on something that is completely unproven and eventually then prove to be completely unhelpful and even dangerous. You got to be careful. So you guys, I'm not trying to be, again, this is not just to be biased. You have to look at the science and not jump on an anecdote or what someone says might work. So how do you do that? How do you evaluate? Well, randomized placebo-controlled trials are the gold standard. There's just nothing else like that because you have a placebo and you can't bias them, right? Everything else can be biased. So you can't trust anecdotal evidence. You can't trust with as much confidence a retrospective or observational study. It can be helpful. I mean, you can gather important information, but just keep in mind that you've got to look at the quality of the study and make a judgment. So let's talk about remdesivir. This is an important one. So this is an adenosine triphosphate analog, which means it's a nucleoside analog. It gets built into the RNA genome as it's being built, and then it basically stops that chain from elongating. So there's lots of these sorts of drugs for HIV, for herpes viruses. It's a great way to inhibit viruses. You inhibit at the level of the nucleic acid polymerase of the virus. So this was actually developed by Gilead for Ebola and Marburg. It wasn't developed for SARS-CoV-2, but a number of labs screened for inhibitors of SARS-CoV and MERS-CoV. So you have heard probably in prior talks or in other settings that SARS-CoV-2 is very related to these coronaviruses. And so, the RNA polymerases, in fact, are very closely related between them. So you can imagine if it works against these two viruses, it might work against SARS-CoV-2. And so in screening against those viruses, they found that remdesivir worked very well, and it even worked in animal models. So there was good evidence that we should try this in humans. Here was a paper that a friend of mine working on coronaviruses was part of, and it's a nice paper establishing that there's conserved structure within the RNA-dependent RNA polymerases of these related coronaviruses. So basically, these authors showed that you could use remdesivir against multiple of these related coronaviruses and be able to inhibit the elongation of the RNA chain. And then they moved this into a mouse model. It was actually a chimeric SARS-CoV with the SARS-CoV-2 polymerase spliced in as a chimeric virus that they did this initial work, and later against the native SARS-CoV-2 virus, and it inhibited very potently. So that was very promising, and remdesivir then went on to other animal models and to clinical trials. This is just a structural representation of the drug in here and in the pocket of the RNA-dependent RNA polymerase, and you can see these coordinating residues and just fits really well and then blocks basically any further additions to the growing chain. Okay, so this is the pivotal paper that came out. It came from a clinical trial called ACT-1, which stands for the Adaptive COVID-19 Treatment Trial. It was a large study with international sites. They enrolled 1,000 patients, over 1,000. The important thing to note is it was double-blind, placebo-controlled, was in hospitalized adults with COVID-19 and respiratory infection. They looked at, as a major endpoint, time to clinical improvement of those who got a placebo versus remdesivir. So if you're doing the trial, you don't know if the patient has gotten remdesivir placebo, and you're reporting all those results. And that is really an important thing. So what they found is shown here. There's a separation between those who recover, and they recover more quickly if they got remdesivir in the blue versus placebo in the kind of reddish orange there. They separated this into different groups, so not all groups seem to really do better, and so not really much difference. There's overlapping confidence intervals here for those who got remdesivir versus placebo. So we don't really use it in those types of patients who aren't on oxygen. Those who received oxygen, there is separation. So remdesivir was better. But you can also see, that the recovery it's not like black and white. There's separation, but it's only a partial effect. So it's important to keep that in mind, that it's not a miracle drug that, suddenly makes someone well, but it certainly could help, and we use it a lot. So overall, the Act 1 results showed a shorter time to recovery, median of 10 days versus 15 days. Lower proportion of hospitalized patients progressed to respiratory failure. So that's good. So they were on oxygen but didn't progress to respiratory failure. Length of stays were decreased. And overall, the study showed that remdesivir is superior to placebo in hospitalized adults with lung disease. So this drug got emergency use authorization on May 1st, 2020, and it is now licensed for use. Now, this is not, things are not perfect. There's disagreement about how good remdesivir is. So, and I think that's important to point out. There was a WHO-sponsored trial that looked at went on looking at lots of drugs, not lopinavir, it should be lopinavir, but basically it wasn't placebo-controlled. It was an open label. They had, looked at local standards, so there were lots of kind of caveats to it. They found that hydroxychloroquine, lopinavir, ritonavir didn't work at all. Interferon beta-1 didn't help. And then they continued their study and found that remdesivir really didn't help in terms of mortality and even duration of hospitalization. So you have to compare this to the Act 1 study. And, most people who have looked at this have come down on the side of Act 1 being more definitive because of the placebo control. So I hope that that's clear. It's, it's not black and white, or this study would have really also probably found an incredible effect. And my interpretation is you have to give, the antivirals have to work, obviously, to shut down the virus replication. And by the time you're in extremis, by the time you have severe disease, it's too late to really get a lot of help from the antivirals. And in the Act 1 study, the patients were a little earlier. That's my take, is that they got the drug a little, the enrollment criteria was slightly different. And so they got an aid because they were requiring oxygen, but maybe not as sick as those in this trial. So I hope that makes sense. So now, how do you make decisions with that kind of data? So you look at guidelines. There are expert panels, and there are several. I would recommend either the NIH guidelines, which are terrific, or the Infectious Disease Society of America guidelines. And the ones I'm going to show you today are the infectious disease guidelines. Since I'm an IDSA member, I'll stick up for my society. So guideline number 1, remdesivir. The panel says first of all, they're looking at, during a time when this is hard and you've got to make decisions because the evidence is not total, you have to basically have experts just say, what is the best thing to do? And what they said was, hospitalized patients with severe COVID-19, you should use remdesivir instead of nothing, basically, in terms of antivirals. And they also always grade these things. So this was with a moderate certainty of evidence. And here's how they define severe. It's oxygen saturation is low. So anybody basically who's getting supplemental oxygen, mechanical ventilation, or ECMO, and for those of you who may not know, that's a kind of heart-lung support, even further than mechanical ventilation. So, and then subsequent recommendations recommended 5 days of remdesivir over 10 days, as long as you weren't on a ventilator. So those became the standard in the United States, and that is what we do. Now let's take a little switch now. Again, to remind you of antivirals versus immunomodulators. The antivirals have to be given early. You've got to really shut down the virus before it has the chance to cause severe tissue damage and the cytokine storm and other, manifestations. So it really has to be early. And the animal models showed if you gave antivirals, very, very early, you'd get no symptoms. You'd get nothing. But of course, by the time we see people, they've got symptoms in general. So it's can't completely extrapolate from that. Now, the immunomodulators, on the other hand, they are there to limit the inflammatory response and to shut down something. They might be useful later on, after the antivirals or at the same time. So far, what has been looked at are these three in detail. There are lots of other immunomodulators. I'm going to talk most about dexamethasone or other steroids, tocilizumab, and baricitinib. Okay, here is a definitive study. It seemed definitive about dexamethasone in hospitalized patients with COVID-19. Now, there's lots of literature out there. I'm picking just selective ones, most of them from the New England Journal, that really have been, crucial during this last year. And some of them are still unpublished. They're in the bioarchive kind of form. So this was a controlled open label study from a group in the UK called the Recovery Collaborative. And they gave steroids basically to individuals with pneumonia and COVID-19. Okay, and let's move this out of the way. Sorry. All right. So what they found was dexamethasone decreased mortality in those who were on mechanical ventilation or just receiving oxygen at enrollment, but not anyone who was not receiving oxygen. So it's not like you give dexamethasone as soon as someone is COVID positive. This has now become the standard. So you've already heard about the two standards, dexamethasone and remdesivir, at least in the US. Here's some of their data. Maybe this looks kind of familiar. This is, again, a Kaplan-Meier, but now we're looking at mortality. And you obviously want the line to be low. And so usual care and dexamethasone, you can see there's a separation. And we wish it was way down here, but it's not. But it's at least helpful. And for those on mechanical ventilation, so this is all participants. This one in B is those in mechanical ventilation. You can see there's a clear separation. So really, dexamethasone made a major difference. If you weren't on oxygen, look in D. This is kind of interesting. It made things a little bit worse, maybe. But the confidence interval doesn't say that that's really significant. But in any case, it didn't help. So if you're not on oxygen, we don't use steroids. If you have an oxygen requirement, we do. So here's the guideline. So again, study, and then we go to guideline. That's how we really try to make our own decisions locally. And then we also create our own institutional guidelines that basically follow these. So guideline number 2, dexamethasone. Hospitalized, critically ill patients with COVID-19, the panel recommends dexamethasone rather than no dexamethasone. And you can substitute other steroids. It's not that one is particularly, there's nothing totally special about that. That was just studied. So you could use prednisone or something else. If they're hospitalized with severe but not critical COVID-19, you still should give dexamethasone rather than no dexamethasone. It's not quite as great an evidence, but that's the recommendation. And then if you have no need for oxygen, don't use it. That's the guideline. All right, so now we have an antiviral and we have an immunomodulator. So what can we do to make things better? The care has gotten better, thankfully. The mortality rate has gone down for hospitalized patients with COVID, and that is a great thing. And it's largely, I think, really due to dexamethasone, but with maybe some input from the remdesivir use. But we want to do even better. So can we do better? And there are lots of studies now trying to do better. So the ones we're going to talk about, IL-6 inhibitors. So early on, it was seen that there's an inflammatory cascade and that those who have elevated levels of IL-6 seem to go into a different risk category where their mortality was higher. There's lots of other cytokines that are elevated, but IL-6 seemed to be an important one. And so using IL-6 to blockade, which is available because it's used in rheumatologic diseases and other disorders, seemed very, very logical. Tocilizumab is an anti-IL-6 antibody that blocks, used in rheumatoid arthritis. There's conflicting data, but more recently the data look positive for adding this in some cases to therapy. So this is not yet published, but it comes from that same recovery collaborative group, kind of preliminary results with tocilizumab. And what they found was there's a significant benefit with hospitalized patients with hypoxemia in addition to the use of steroids. So that's what we were really looking for. If we used it, well, no one's going to use anything without steroids now for those on oxygen. So, but this can add. And this one has, one of the advantages of this particular study that's ongoing is it's a large sample size. And that may be why they're seeing something that some of the smaller studies didn't see. So the study suggests that immunomodulatory therapy of steroids and an IL-6 inhibitor should be pursued. But then if you're a clinician like me that's not doing therapeutic trials, because we're doing vaccine trials, how do you know exactly how to use this? And again, the way to do it is look at the guidelines. But first, let me just this is a very clear curve. Again, I'm showing you a very similar curve, but now we're looking at mortality. We want that to be low. Here's the group that got usual care, which 80% of these individuals got steroids. And then tocilizumab was added, and you can see a big separation. So that is pretty impressive to me. So I think, at least in some patients, that is going to be an adding benefit. How do we use it? And we go to the guidelines, and what they say is among hospitalized patients with progressive, severe, or critical COVID-19 with elevated markers of systemic inflammation, and that is a lot of them, the panel suggests tocilizumab in addition to the steroids. Because there's a lot of conflicting studies, they say low certainty of evidence. So this still requires, a lot of these things still require further evidence and further study, but this is where we are today. So that's good. I think, someone is, especially if they're on Remdesivir and Dex and they're not getting better, and things look severe and they have lots of elevated cytokines, add this on or add another IL-6 inhibitor.
Hey, Dr. Spearman, can I interrupt with a couple questions?
Sure.
Cool. So Ashley had a question. Is Remicade helpful as it's also an immunosuppressant for RA and Crohn's disease? Do you know anything about that specific drug?
Let's see, Remicade. I have not seen that studied. I could look it up, but I'm not going to look it up right now. I do not know. If anyone else online knows that, let me know. I've not heard of that in this disease.
Okay. And Ashley's other question is, so I'm guessing like in the drug design process, is the complement cascade being involved at all? Like, is that a logical target?
I think that's a very logical target. Yeah, and someone can give me the generic name for Remicade. I might do better. Is that infliximab? Maybe Ashley knows.
Ashley said.
Yeah, yes. So it's actually a good question. Infliximab, it has been looked at, and it's being used in things like MIS-C. So is it helpful in hospitalized patients with COVID pneumonia? I haven't seen a publication to say that, but it's a very good question. Yeah, and repeat the second question again.
Yeah, that was everything. And then the second question was, is the complement cascade?
Yeah, so the complement cascade is being looked at, and there are attempts to control that as well, but I haven't seen anything, there's nothing in the guidelines about how to do that for therapeutics. But those are all great questions. There's also, of course, a lot of problems with thrombosis in COVID patients, and there's not a universal preventive yet. There are certainly treatments, once you have some thrombosis going on. So there's lots of other pathways that aren't yet in our general guidelines for how we deal with COVID. But those are all good things. Okay, I'll talk about baricitinib. This is a JAK1, JAK2 inhibitor. And this is it's basically a step in a cascade that produces multiple cytokines. So, it includes it includes knocking down IL-6, for instance, which toci does, but it also hits IL-10, interferon gamma, GM-CSF. So, a very powerful anti-inflammatory. So the ACT-1 trial was the trial of remdesivir. This was an interesting trial that has an adaptive design, which means once you find, in their case, what it means is once you find one thing that works, then you put that as the standard and you add something else on and see if that helps. So you compare remdesivir versus remdesivir plus baricitinib. And that's what they did for the ACT-2 trial. And they were looking at hospitalized patients with COVID-19. Again, one strength of this type of trial, it's a randomized, placebo-controlled, double-blind. And what these investigators found was that baricitinib improved time to recovery and overall clinical status. Now, this was going on just at the same time, and had been going on a bit before the results with steroids came out. So this did not involve steroids and baricitinib. So that you got to put that in context. So what happened was it looked very promising. And yet steroids like dexamethasone look so good that the guidelines say among hospitalized patients with severe COVID-19 who can't get corticosteroids, use baricitinib, which has, it's not a steroid. So you can use that with remdesivir instead of remdesivir alone. And if you're going to use them all three together, that is recommended by the guidelines only in the context of a clinical trial. So we can know if that's the right thing to do. Because, you could guess that's the right thing to do. It might work. And maybe some individuals are getting that, and I'm sure that's happening. But we'd love to know that in an ongoing trial. So that is another choice. We have tocilizumab, we have baricitinib, along with remdesivir and dexamethasone. So we're building up some drugs now to really use in this difficult condition. And that's sort of summarized here. We've got one antiviral that's approved. We've got these immunomodulators that look, well, there's good evidence that they work. Dexamethasone, tocilizumab, and baricitinib. Toci is people still debate that a little bit. So keep your ears open for how that plays out over time. But this is sort of a take-home. If you guys can remember this, then you're up to current sort of standards with, now there's a lot more, of course, people trying other things as well. Well, what about convalescent plasma? This is a interesting dilemma for a lot of us. So what happens, it's logical. You would think those who recovered from COVID-19, the virus is gone, they donate their plasma, you collect it in the blood bank, it's done routinely, it's easy to give plasma to patients. So now you're giving them polyclonal antibodies against the virus. So wouldn't that be a great thing? And that was promoted very early on before we even had monoclonals or other things to deal with. So theoretically, that could prevent disease in those who are at high risk. And it also could treat those who have severe disease or those who have any disease. Now, this became very widely used. There was an expanded access program, and then there was emergency use authorization. But this particular emergency use authorization announcement got a lot of criticism. I'll just briefly tell you why. So again, I'm not picking on the last administration, but this came out, convalescent plasma, back in August. There were claims made that were totally false about how useful it was, like reducing mortality by 35%. If you looked at the data, there was nothing that said that, not even a hint. So there was no reality there, and so there was, lots of criticism about why did that happen. I think I don't know for sure, but since the FDA did give emergency use authorization, I'm sure there was a lot of pressure. They looked at the real data, and there was some promising signs in the data, but there certainly wasn't this 35% reduction. And so that announcement was wrong. And whether FDA was wrong, I'm going to leave that, I guess, but it certainly got a lot of criticism. So basically, the day after FDA said they would authorize this, the NIH guideline panel said, we don't recommend anyone using it. So that was not a great thing for confidence in what we're doing. And thankfully, the EUAs that have come about for vaccines, if you put those in contrast, they have been very well done. The data have been solid, and the FDA's done a very good job of handling them. So, you have to kind of put that in contrast to this. This didn't seem to go so well. Let's talk a little bit about an EUA. What does that mean? Emergency use authorization. There are federal, procedures, there are regulations that basically regulate what the FDA can do. And one of the things they can do is to give an emergency use authorization for medical products. First, there has to be a public health emergency, and the pandemic was declared a public health emergency. It certainly is. And then the FDA conducts a risk-benefit analysis to see if, with a little bit less evidence than would be required for full licensure, if the benefit of something in an emergency situation outweighs the risk. And so they do it carefully, but it's not the full data set you'd have for licensure. So basically, it becomes a risk-benefit analysis. The FDA commissioner has to say there's, known and potential benefits that of this that is worth doing, more than the risk. And the standard is lower than the level of evidence for, the total product approval or licensure. So that's a judgment call to some degree, but still a lot of data required to really get to this. And I've seen the data reviews more for the vaccines than for the therapeutics. And the data reviews for the EUAs, including the VRBPAC reviews and things, are very, very thorough with lots of experts weighing in. And so that looks like a very solid process. And if they weren't doing that for vaccines, we wouldn't have any vaccines at this point. And, so I think there's a reason for being able to do EUAs. Okay, but back to convalescent plasma. So prospective trials to see if this stuff works are still in progress. You have to have high neutralizing titers in the plasma or it's not worth using. And FDA amended their EUA to say you have to have certain, titers greater than 1 to 160, which means the ELISA values have to be quite high to get that sort of neut titer. So some of the data so far looks like the effectiveness is very, very limited. You have to get the plasma very early on after being diagnosed. And in hospitalized patients, unfortunately, it looks like there's no benefit. So really, now a lot of us have used convalescent plasma, prescribed it in hospitalized patients, and now we're being told we shouldn't. So, which is probably correct. Here's this is unpublished data, again, from this recovery group. They did a very large study of convalescent plasma in hospitalized patients. This is available on the bioRxiv if anyone wants to look at all the data. So they used high titer plasma, which is what we're supposed to do. They had nearly 6,000 patients in both the treatment and control groups, and they found no benefit at all in mortality and some other outcomes, but the main one was mortality. Disappointing. Here's the curve. Can you see any separation there? I can't. So that's convalescent plasma with or without. You guys can decide. But unfortunately, I now downplay convalescent plasma in our hospitalized patients. We still occasionally will certainly let people use it if they want to use it, and they have a good reason to. So guidelines. You go back to guidelines. I'm not the expert. I look to the experts who say, what should we be doing? Among patients hospitalized with COVID-19, the panel suggests against COVID-19 convalescent plasma. It doesn't mean it can't be useful in the outpatient setting or in other settings that are still being evaluated. So, but hospitalized patients, nope. All right, monoclonal antibodies. You've probably heard about these. Many people have trouble with their names. I wish they'd make easier names. Bamlanivimab, etesevimab. That's the Lilly combination, and casirivimab, imdevimab. I couldn't say that without looking at these names. I can't remember them. But so one is Lilly and one is Regeneron. These are both, so that both of those are combinations, two different monoclonals given together against the SARS-CoV-2 spike protein, the outer protein that binds the receptor. It used to be that there was an EUA for bamlanivimab, or the Lilly antibody alone, but that one was withdrawn because some of the new variants show that there's reduced efficacy of that one alone. But if you have the combination, it's still fine. So now no one gives the one antibody, but they can still use combinations. And a proven indication is prevention of severe COVID-19 in those who are at high risk for disease. It's not 100%, but it can help to prevent individuals to progress to severe disease if they're at high risk. And here is one of those. This is actually from the bamlanivimab alone, which used to be called LY-CoV555, the Lilly monoclonal. And you can see from this paper that it reduced the viral load, meaning it was decreasing viral replication. It improved symptom scores, and it reduced hospitalizations. And basically, the hospitalization, so this is a drug you give as an outpatient, and it prevents people from going in the hospital. So 1.6% versus 6.3%. So you have to give it to a lot of people to see this effect. That's another thing to take into account. They're very expensive as well. So, but it's a serious thing if you get hospitalized. And here are their high-risk criteria. I'll let you guys read them, but they're different for adults and kids. Basically, anyone over 65 is at high risk, and then lung disease, cardiovascular disease, diabetes, chronic kidney disease, immunosuppression, and obesity. Those are the basic categories. And in adults, similar, but you could also have sickle cell and congenital heart disease and neurodevelopmental disorders, and then some of the chronic kids that have trachs and things, and asthma. So if it's severe asthma, not mild asthma. So there are specific criteria for those who we give the monoclonal combinations to. And the way we do it at Children's is we have a little committee that, not a little committee, but a committee that we get requests for the monoclonals. We just review briefly the patient characteristics. And if they meet what the emergency use authorization criteria are, we basically always allow the use of the monoclonal to try to prevent progression. So here's what the guidelines would say. For ambulatory patients with mild to moderate COVID-19 at high risk for progression, so those kinds of chronic diseases or obesity or elderly folks, the committee suggests using one of these two combinations. Not much differentiating the two so far, and they haven't been compared head to head. Slightly different in the testing that was done in terms of ages, et cetera. But otherwise, you can think of them as equivalent. All right, so those are basically what we have to use. Now, what about all these other things? Lopinavir, ritonavir, hydroxychloroquine, azithromycin, ivermectin. No. Just stay away from all that silliness. That went on for a long time, and people, proponents of different things, we probably shouldn't go there. But it was basically for some of these. I think what happened was for some of these, there was some in vitro evidence of blocking viral replication, but for most of them, it didn't go anywhere beyond that, like into good animal model evidence, and certainly not into humans. So a lot of wasted time on some of these, and some severe toxicities, especially for chloroquine and hydroxychloroquine. There are some other drugs in development. Obviously, we need a lot more drugs because these are all just repurposed things and immunomodulators. So here's one that could be exciting: molnupiravir. It came out of Emory, which is my old digs from years ago. So this was it's another inhibitor of the RNA polymerase. So it's another nucleoside analog that basically kind of a chain terminator. It's a tricky one that fools the polymerase, sort of. It's an oral drug. Now that would be nice. Instead of a IV or intramuscular antibody, now or Remdesivir, which is IV, now you can take an oral drug. So that's promising. It has good-looking antiviral activity. Really, suppresses the viral load. Just recent, we don't have the data to look at much in terms of real published data, but a recent press release. This is now developed by Merck. It looks like their trial for inpatients wasn't dramatically effective in inpatients. But if you think about it, that's probably like remdesivir. It's not dramatically effective as an antiviral. But in trial for outpatients, and that'd be hard to do with remdesivir, which is IV, but their outpatient therapy, this is really promising. That would be terrific to have, someone just gets a COVID diagnosis and you start a drug to use to prevent any progression, and you just take it by mouth. So let me just recap. Those are the big points. So for hospitalized patients with severe disease, we use steroids and remdesivir. And then sometimes we will add other anti-inflammatories that have had solid evidence. Tocilizumab is a choice. It's still undergoing some evaluation. There are other anti-inflammatories that, depending on what's going on with the individual patient, that are added, and probably better to hear that from the ICU docs and some of the rheumatologists who are also weighing in on a lot of the choices. If there's a contraindication to steroid use, then use baricitinib. That's well established, nice trial. Convalescent plasma, really we need data to show us how to use this because it's not working in hospitalized patients. And so there's still potential it would be helpful in the outpatient setting, but since we have the monoclonals, I think this is going to kind of go away. And then the monoclonals, outpatients who test positive and are at high risk, that's the current indication. There are likely to be additional indications. There are newer monoclonals and new trials looking at can you give it early after disease manifestations start? Can it help for more of a therapeutic instead of a preventative? So I would keep my ears open for those two. And that's basically what I know about COVID therapeutics. So I am happy to take any questions, and I hope that sums up the field relatively well.
Fantastic. Well, thank you so much, Dr. Spearman. This was really interesting, and I think you did a really excellent job overviewing everything, all the, cool drug candidates. So we have some questions coming in the chat. So the first question Ashley asked about 10 minutes ago was, do you know anything about whether thrombotic microangiopathy is being seen in patients with COVID?
Yeah, there are a lot of thrombotic complications. I mean, there's large vessel and small vessel thrombosis, but specifically thrombotic microangiopathy, I would have to look and see. I'm sorry, I can't. I mean, there's odd thromboses like the things you get like COVID toes, and you've probably heard of those. But there's also severe large vessel disease and cerebral vascular accidents and severe disease. So there probably is, but I can't speak much to that.
Okay. And Charlotte wanted to know, why have some treatments, such as remdesivir and dexamethasone, only been shown to be effective in COVID-19 patients that require oxygen?
Yeah, that's a good point. I think it's because they've already progressed to a certain part of their illness where the anti-inflammatories can really reverse something. Whereas if you're giving it to all comers, there's a lot of folks with COVID who don't progress. And so if you give steroids to everyone, they're going to get some GI bleeds and some other symptoms that might actually make things worse and it's not going to necessarily prevent them from getting the manifestations of SARS-CoV-2. But it's a good question. Why we didn't know that wouldn't work until the trials just said. So basically, it's the data from the trials, and you could have guessed that maybe giving steroids earlier might have been good. It just doesn't show that from the trial. So it's a good thought.
Great. And Hannah was wondering, so how do you go about giving immunomodulators so as to not oversuppress the immune system while still fighting off the virus? Like, how do you kind of walk that tightrope?
Yeah, no, that's a good point. We haven't seen that the virus gets way out of control once you give a steroid or other immunomodulator. What normally if you look at the viral loads that you measure in the respiratory tract, when someone presents with disease, with symptomatic disease, there's kind of a level up here that drops down and it just keeps dropping down. It may stay persistently positive for a long time, but it gets lower and lower and lower, as if the virus has done most of its damage by the time you detect, that it's there. And so it doesn't seem that the virus then rebounds and gets much worse with immunomodulators. The risk is there that you'd think it could, but I don't think we've really seen evidence for that. So now we do see on the flip side of that, those who are on severe immunosuppression, transplant patients, chemotherapy patients in particular, can continue to show replication of SARS-CoV-2 for months and months and months. So that has also been well established. And that is because of their immune suppression. And it's tricky to know, like when someone like that gets a fever, is that because the test is still positive, is it SARS-CoV-2 or is it something else? And so it's still a good question. Is the immunosuppression is the virus doing some damage months later, or is it just hanging out at a low level? So we deal with that question a lot. And in most cases, it seems to be that it's just viral blips and viral secretion rather than now several months later, they've got a COVID pneumonia. But that doesn't mean that's in every case, because they are immunosuppressed.
And Suhas was wondering, is methotrexate considered a potential immunomodulator here?
I haven't seen that studied in COVID. I bet somebody has. I just haven't seen that. It's not in the guidelines. Would it be helpful? Yeah, I can't speak to that. So it's not a bad question.
Great. Well, I'm not seeing any other questions come in. So, yeah, again, thank you so much for being our final lecture of this course, especially since you're on family vacation right now. We really, really appreciate it. It was a great lecture.
Back to the kids. Well, thank you very much. I hope everyone has a great day and great week.
Great. Thanks, Dr.
Bye-bye.
Spearman.
Thanks, Paul. We'll see you later.
All right. Take care.
All right. And while you guys are all, I think a lot of you are logging off. So I just want to give a quick reminder that your final paper is due, I think it's like next